Hello and welcome to the first episode of Hema Now, a new podcast series from EMJ with me, your host, Dr. Jonathan Sakia. This series was designed to give a space to haematology, spotlighting the latest advancements in the field and raising awareness of current challenges in clinical practice. Bi-weekly, I'll be joined by leading haematologists, making it the go-to place for healthcare professionals in the field. We have an exciting lineup of guests in store, and our guest today is no different. I'm thrilled to welcome Dr. Sunil Gupta, consultant haematologist and haemato-oncologist based at Lewisham and Greenwich National Health Service Trust here in the UK. With over 21 years of experience in clinical and laboratory haematology, Sunil has trained at some of the world's most prestigious institutions. These include King's College Hospital, London, the Royal North Shore Hospital in Sydney, Australia, National University Hospital in Singapore, and the All India Institute of Medical Sciences in New Delhi. He achieved his certificate of completion of specialist training from the London Deanery at King's College Hospital. Specialising in haemato-oncology, Sunil has clinical interests in clotting disorders, anaemias, myeloma, and thrombosis. He led haematology research and development at East Sussex Healthcare and Lewisham and Greenwich National Health Service Trust, initiating several clinical trials in haemato-oncology. On top of this, Sunil Gupta has been involved with various charitable organisations in Britain and India, including being named the local COVID hero by the Member of Parliament of Orpington for his pandemic-related community efforts. In May 2022, he was elected as the ward councillor for Bromley Common and Holwood, also here in the UK. And Sunil's also a member of the British Society of Haematology, the European Haematology Association, the Medical Protection Society, and the American Society of Haematology. When he's not busy advancing the field of haemato-oncology, Sunil can be found in the yoga studio. Self-described sports enthusiast and fitness freak, Sunil is an accredited yoga teacher and holds weekly classes in Bromley. Welcome to the podcast, Dr. Sunil Gupta. It's an honor to have you here. A while back, I was being encouraged to try yoga, and I sort of was dismissive of it. And after 5 minutes, I thought, holy goodness, this stuff is hard. But it's got an amazing background with serene origins many thousands of years ago in the Indus Sarasvati civilization I was reading. And nowadays, of course, it's all about stretchy yoga pants and hot yoga and Lord knows what else. And to start, tell us what inspired you to become an accredited yoga teacher, and how does your interest in health and wellness sort of complement your work in the complex and sometimes very frightening field of haematology and haemato-oncology?
Thank you for this question. I think that's a very good introductory question. It's quite natural, being from Indian origin, not to specialize in yoga, not to have any interest in yoga. So I would say, if I kind of go back in history, then my interest in yoga started from the age of, say, 7 or 8 years. And I still remember discreetly that I was invited amongst my other school friends or my batchmates of year 7 or year 8 to demonstrate yoga on the National Sports Day in a primary school or secondary school. And that was the day when that was my first appearance on a stage. So my introduction to stage started then. And I think then living in India for good 35 years, getting into yoga is pretty natural. You can't actually stay away from yoga. Every nook and corner of India is having some kind of an organization doing some yoga gatherings in the morning. You go to any park and you will see laughter from people because they're doing laughter yoga. So it was quite natural for me to get into yoga. And I think it is clear that yoga has got health benefits, undoubtedly, and that's what it is for. I would like to also mention about the other wings of yoga. So yoga is not only about making postures and
Well, in fact, that whole thing, I'm trying to remember the name for the poses.
asanas.
Asanas,
Yes.
right. That's a comparatively recent development. Going back, and I believe it started in the United States. I was reading the history of it, that it really is more about mindset and meditation and relaxation. That's correct, right?
Absolutely. So I was actually coming to that point that yoga is not only restricted to meditation and mindfulness and yogasana, and also about breathing. So it has got 8 wings or 8 arms, so to say, and that also includes how to become a better human being. So it actually also builds up your character. So if you put a child early on into the yoga curriculum, it also helps them becoming a better human being. You inculcate good qualities. Things like not to lie, not to harm anybody, not to grab money, not to be greedy. And then, of course, then comes the breathing part of it, and then the stretching part of it. So that's your mental well-being and physical well-being. Now, if we're actually trying to translate the science of yoga into medicine, it is pretty easy, I would say. Look around. What's happening in the NHS? Where the entire money is going? The money is going into mental health. The money is going into diabetes. The money is going into hypertension, the cardiovascular problems. And all these things are prevented or can be prevented easily if you actually put the children or put the habit of doing yoga or any physical activity for that matter early on. And that actually will have a far-reaching benefit on the NHS budget, because prevention shouldn't be forgotten. And I think what the problem is at the moment is that there's more emphasis on treatment and less emphasis on prevention. So if you push yoga into school, into a regular curriculum, it can have far-reaching benefits on the society at large for their mental and physical well-being.
I'm completely with you. I mean, we don't have a healthcare system. We've got a disease care system. I spent half my life in the United States where it's exactly the same. And if we would do things like that, and if I hear one more person tell me about, shortage of funds for physical exercise programs in school. Well, when I went to school, physical exercise was running around the playground with a ball, for goodness sake. You don't need to, not everything has to have a price tag next to it. And I also, and I know you know 1,000 times more about this than I do, when I looked up at the health benefits of yoga that have been subjected to the stringent measuring stick of randomized controlled clinical trials, it's shown to reduce analgesic requirement post-operatively, reduction in nausea and vomiting in patients receiving chemotherapy. So, rah-rah, I wish you huge success in promulgating this. And I think we need to investigate alternative means of making people healthy. Here's a quote that I heard many years ago and I love. Disease is actually 2 things. There's the disease, the part that's gone wrong functionally or structurally. And then there's the dis-ease. There's the concern and the fear and the worry that goes along with it. And yoga can help with both of them. So more power to your pencil, bring it on. Tell us, let's get in a bit into the hematology and haemato-oncology. What got you into this specialty? What's your life journey?
Excellent. So I think that brings me to another question in which I'm taking more interest these days, and I've been always taking interest in what you call art of manifestation and what you call art of attraction. So throughout my life, especially right from the beginning of my my life, so to say, because at the age of 5, I knew what I will be when I'm adult. I knew I will be a doctor. So I used to go to the hospital. My father used to take me to the hospital for various things. Like I remember a eardrum perforation, and I went to the hospital, and I was in pain. But when I went to the hospital, I forgot about it because I was more embroiled in looking at the doctors, their uniform, at the nurses, their uniform, the smell and the odor of the spirit, the disinfectant. So I got drawn right from the early age towards doctor, and I started manifesting myself, seeing myself into that white apron. And that actually came true, even though, unfortunately, I lost my father when I was only 16. From there onwards, it's just the art of manifestation and the art of attraction that I visualize myself as a pediatrician to start with. So I started visualizing, or rather getting attracted towards this word called pediatrics. I said, well, pediatrics, what a fantastic word. And I'll be a pediatrician, and I became a pediatrician. And when I was in my last year of pediatrics, I got drawn towards leukemia. Oh, what a fantastic word. And then, of course, then the world of leukemia and haemato-oncology unraveled from then onwards. And if you look at the quality of being a hematologist, that you have got a capability of diagnosing the patient yourself and then taking the patient through their journey of treatment and possible cure and the side effects. And it's a long journey. And in haemato-oncology, you quite often have got a fruitful outcome where the patients either get better and stay with you and they're in remission. They have a long journey with you. So you develop a relationship with them, kind of a patient-doctor relationship, and you look into their, peep into their lives, into their social issues, etc. So as a wholesome, you have got a very holistic approach towards your patients. And if you look at the other side of hematology, which science has actually done more progress than haemato-oncology? I think I can't find much. Haemato-oncology has expanded massively in the last 10 years. We have got so many inhibitors, we have got so many monoclonal antibodies, now we are getting into the CAR-T. So research and activity, teaching, patient journey, satisfaction treating a word like cancer, and also there is a glamour of what you call acute medicine, because hematology oncology patients can become unwell very quickly.
Yeah.
And then, of course, as I said, the lab side of things. So you take the patient from the lab to the bedside, then take the patient throughout their journey. So I think haemato-oncology is a very exciting field, and that's the reason I'm also hematology, as career champion. So
Clearly, you're doing a very good job. Rah. I have to say, for many years, I've been involved with a triumvirate of children's charities: Starlight, Star Bright, and First Star, from the nursery rhyme, through the work of a chap named Peter Samuelson. And I'm reflecting on my time with the charities, and when I first got involved, much earlier in my life and my career, children with some of these wretched acute leukemias, they didn't survive, and the charity arose, the awareness that these children needed a last wish, if you will, rather like the Make-A-Wish charity. Well, today they don't die. They don't need a last wish. And my goodness, for you and your colleagues, bless you for that. So, Sunil, you're clearly a citizen of the world: India, the United Kingdom, Australia, Singapore. In my field as a surgeon, I've had the privilege of going to teach all over the world in sometimes so-called lesser developed countries. And my experience was, for anything that I taught, I learned 10 things. And it was probably the most enriching thing I've done in my career. What are your perspectives about traveling and being educated and teaching and working and various stages of your career globally? What are your perspectives? What can we learn from these different places, and how do we as physicians in what is a very troubled world use medicine to bring people together?
Thank you. I think I would call myself quite fortunate in that sense, because I worked in very developed kind of hospital or medical setting. India was, of course, in those days, I'm talking about 1998 when I started my hematology journey, all the way to the early 2000s, and then moved to Singapore. So it was a complete shift for me from a setting where We didn't have much in terms of the support for poor patients in the government sector. We were not working on computers. There was no patient record system. And then suddenly moving into a very advanced setting in Singapore where everything is electronic, no paper-based care was being done. So it was a real shift. But I actually learned things very quickly, and I was appreciated by my Chinese consultants in Singapore that, barely a month ago you arrived from India, and now you're quite good in it in terms of looking at the results and kind of conducting things electronically. So I learned electronic version and advanced setting in Singapore, where we had similar kind of setting where we have in the UK. We have got a hybrid system, a private and the government sector healthcare system. And then I moved to Australia. Again, we have the similar kind of system, hybrid system, where if people want to have the private sector care, they can, if they can afford, they can actually access it. And then, of course, moving to the UK. So in terms of learning, the one thing which I would actually think that I learned is to get into the system and team working. So even though you're moving countries every year, but it is your ability and adaptability to get into the new system, to get into to work with a different cultural background system, and also patient. In fact, in Singapore, I learned a little bit of Chinese as well.
Right.
The other thing I would like to say that I also learned that how you can make the best use of, say, low-budget healthcare system like in India. How to extract from the local people. If the local people can become your healthcare workers, it will employ them, and also it will be a low-budget thing for you. So one of the hospitals which I am actually supporting in India is actually a rural hospital in thick forest of central India. And I got really struck by the fact that they are utilizing the local resources to make up for the costly, healthcare workforce. Similar kind of thing was there in Australia. They were going into the remote areas, into the rural areas or Aboriginals area where the health system was not as robust. So they were trying to, what you call as leveling up, that those areas shouldn't actually be left behind, and they were trying to level up. So that was one thing that, it is the health accessibility of healthcare system accessibility should be equitable. That is happening in the UK as well. We are trying to make sure that every race, every area of the country should have equitable health accessibility in terms of clinical trials, in terms of the drug accessibility, and so on and so forth. So I think these are the few things I would actually highlight in my journey, or what you call as globe-trottering. And if other colleagues of mine or juniors are actually thinking about it, or thinking, traveling the world and try to extract good things and learning good things from various health sectors, then I think this is what we need to do.
100%. And anyone that I would mentor, I'd say the same thing. Spend time away, go learn different, and the friendships that you build. And yeah, I think that willingness to say, well, you know what, maybe we don't know it all. Maybe there are better ways of doing things. So I want to get really specific. A 2020 article of yours, Acute Promyelocytic Leukemia Lying Under the Mask of COVID-19. It's a great title, Diagnostic and Therapeutic Conundrum. Talk to us about this and more generally, the impact of COVID on your practice at the time, on your patients. Because we need to think about the next pandemic. Everyone behaves like this was, oh my goodness, where did this come from? Well, just go read the history books, right? So first of all, that article, tell us a little bit about that in summary, then tell us about how COVID affected your patients at the time.
Yes, I'm sure that all the health organizations around the world had to modify how they practice during those difficult times. In terms of reorganizing their clinics, reorganizing their patient. This particular patient was quite intriguing And I should say that I was very fortunate to be around that time, and I luckily didn't fall ill because of COVID. And I was the one who first flagged that this patient is not a COVID patient. I mean, whatever is happening is not but COVID. There is something behind which we are missing, and that is more dangerous. So as you would know, and my audience, especially those who are with the hematology bent of mind, they would realize that acute promyelocytic leukemia is a very interesting, a very fascinating disease, which has got a lot of things which are very unique in terms of the genetic translocation from there all the way to the treatment, and also the best prognosis of acute myeloid leukemia. Acute myeloid leukemia is one of the in previous days used to be a very poor prognosis and like a death sentence. But acute promyelocytic leukemia, if you pick in time and start the treatment on time, I'm saying like right in the middle of the night, 3 a.m. If you suspect a patient of APML, just start ATRA and the patient outcome could be entirely different. It is that kind of a disease, and it is a fully curable condition even without the chemotherapy. So this patient presented with thrombocytopenia or low platelet count, and also anemia. And the startling thing, which actually made us think out of the box, because at that moment we were just thinking about COVID in every patient.
Yes.
It was
at
the top of the middle of the heart of the pandemic, and we were just kind of dreaming about COVID in every patient. So this patient came about. We found that he had a high fibrinogen and a deranged clotting with a raised prothrombin time and APTT, or activated partial thromboplastin time, with thrombocytopenia. So thrombocytopenia can happen in COVID, clotting derangement can happen in COVID, and fibrinogen can also be raised. So at the outset, it looked like that this patient had COVID, and the patient had also a lot of respiratory problems. So the first diagnosis was COVID. Let's start the COVID treatment, put the patient on dexamethasone and oxygen, etc., etc. But the thing which actually intrigued us or made us think out of the box is the persistent, profound neutropenia, a low neutrophil count. So I actually started thinking about why this patient is neutropenic, and I looked at the blood film and I found that there were few suspicious cells. And APML is a diagnosis which should be, or which is generally made on the peripheral blood film in the middle of the night. And I got suspicious. I think we should do urgent bone marrow this man, because neutropenia is rather unusual in COVID. We get more lymphopenia. Mm-hmm. And the thing which was, and we found that this patient had, in fact, acute promyelocytic leukemia, which was confirmed by the FISH testing on the bone marrow biopsy and aspirate. But the thing which is unusual in this patient was the fibrinogen was not low, which you generally find hyperfibrinolysis in acute promyelocytic leukemia, which was not there. So we have got the diagnosis, and we know that this patient is actually sitting on the time bomb. He's got COVID. He's got a chest symptoms. He's got deranged clotting. He's got thrombocytopenia, not as severe as you could.
What kind of numbers?
I think his platelet count was around 60 at the time of presentation. Hemoglobin was around 80, and the fibrinogen was raised. So we promptly started this patient on ATRA at a 50% dose, and we also started on arsenic trihexyl, ATO, which is a standard of treatment. And we were quite cautious about this patient because we are dealing with two contrasting things.
Sure.
One condition can give you thrombosis, the other one can give you bleeding. Yeah. So APML is more associated with DIC kind of picture, and patients can very quickly have brain bleed, and then they can have very poor prognosis. So considering that this patient might also go into the other side of having a cerebral sinus thrombosis or intravenous thrombosis, we put this patient on low dose enoxaparin. His renal functions are known. And also we were quite concerned about whether this patient might also develop what you call as differentiation syndrome or ATRA syndrome, where the patients can develop acute respiratory distress syndrome and they can go on a ventilator and can have a very poor prognosis. So we started him on steroids, not only for COVID, but also for as a prophylaxis for differentiation syndrome. And APML is a condition where if you start the treatment on time, the patients tend to become better within hours and days and maximum 1 week. And that's actually what happened with this patient.
Has this now been widely recognized as an issue? Have there been other cases people have reported of this, or is this sort of like a rarity?
I think it's a rarity. It's not something which is commonly associated, and APML itself is not a very common acute myeloid leukemia.
Well, like there were articles in my field in, like surgery, abdominal pain in COVID. Well, guess what? People still got appendicitis, perforated diverticulitis, obstructing carcinomas, and so on and so forth. But it's a key point. So you mentioned coagulation abnormalities being seen in both conditions. And you've talked a little bit about the diagnostic criteria that we used in this case. Any comments on, in your specialty, are people looking at, well, what could happen next? What could the next, just as crazy as, I love science fiction. And there was a book many years ago, I think it was Michael Crichton, and they made it into a movie, The Andromeda Strain, where a microorganism is transported to Earth on an asteroid or some such thing, and it caused this thrombotic disease, and people's blood would just basically clot and turn to powder, and people were just dropping dead like flies. I saw a statistic that in one species of bat in southern China, one species of bat had over 6,000 coronavirus species. It's not a matter of if, it's a matter of when. So given the fact that there were microcoagulopathies in COVID and all sorts of other weird and wonderful things, is your specialty getting involved in surveying what's out there and these zoonoses that can hit us next, or is it kind of be reactive? Bit of an off-the-cuff question. But...
No, absolutely. No, that's a very pertinent question, because not only the COVID caused the problem of thrombosis, mind you, the vaccination also caused the problem of thrombosis, and it also caused thrombocytopenia. And that moment when we had this, the thrombocytopenic thrombosis, which was cat vaccine associated, we were completely lost, and we didn't know how to actually investigate it and how to then eventually treat it. And there were loads and loads of patients who presented with thrombocytopenic thrombosis after either with the COVID or after a vaccination. There were few and far between, and I'm not actually saying that vaccination...
I was going to jump on that because, I talk to my non-medical friends who go off on an anti-vaxxer rant, and I say, well, look, I had the vaccine and I was very ill with COVID, but I'm convinced that, if I hadn't have had the immune support of the vaccine, I wouldn't be sitting with you here today. And the data are very clear. Vaccination saved countless lives.
Well, I hope you enjoyed that first part of my conversation with Dr. Sunil Gupta. Please tune in next time where we continue our chat.